the doctor tells them that all the reports are normal. So they do a semen analysis, it's normal, scan is normal, and even the tubal patency test is normal. And still they are prescribed some kind of medications. They keep trying, but they don't get pregnant. They spend lots of money, but they don't have an answer. And they come to us with that $1 million question as, why am I failing? Why? What is the problem? Wherever we go, everybody says everything is normal, but I'm still not conceiving. This is a common clinical scenario that we come across in our practice. So that is the importance of this topic, unexplained infertility. It is not only a diagnostic dilemma, it is, when you are fighting an invisible enemy, it's good to have some guidance. And it is very common as well. Almost 30% of infertile couples actually have this problem of unexplained infertility. So coming to the definition, so we have the RCOG guideline in 98, we have the ICMART definition, ASRM, and the recent ISHRE definition. So let's look at the ISHRE 2023 definition, which says that if you confirm ovulation with either urinary LH kit or a serum progesterone or a serial ultrasound monitoring, and you confirm tubal patency with a simple HSG or HyCoSy, and the semen analysis as per the 2021 guidelines, if it is normal, you can label the patient as unexplained infertility. This is what the ISHRE 2023 guideline says. But the question is, are we actually excluding enough? So just by doing these 3 investigations, are we justified by telling that the patient has no problem at all and she can still try normally, naturally? And if at all she can try, then for how long can she continue trying naturally? So there are so many other tests that we can probably think of which might add some value when we are investigating her. So when we do these 3 investigations, we are not looking into the oocyte quality. There is currently no way or no investigation where we can actually test the oocyte quality. Male, there are so many sperm function tests that are available. So we have the ROS, we have the DNA fragmentation, we have sperm function tests that are available. When we do a tubal patency test, we are only seeing if the tubes are open, but we don't get an insight into the functionality of the tubes. Tubes being open doesn't mean that they are functioning. Tubes being open, also we don't know if the tubo-ovarian relation is actually getting maintained. So we have some tests like the chlamydia antibody tests, where they say if it is positive, doing a diagnostic laparoscopy will give us more insight. We have some cervical sperm mucus interaction tests that are available. We have a whole lot of endocrinological problems that could be associated with infertility. We have a whole spectrum of immunological problems that can actually be diagnosed. We have the endometrial receptivity tests. So we usually don't do it on a regular basis, but it actually tells us if the endometrium is receptive to a embryo when we do a transfer or when the patient is trying normally. So there are so many uterine abnormalities which you can miss if you're doing only a 2D ultrasound scan. Not all of us have access to a 3D ultrasound scan. So in a 2D ultrasound scan, may not be able to pick up so many uterine anomalies. So adnexal adhesions could be a cause which can be missed with these 3 simple investigations. And any subtle endometriosis. So grade 1, grade 2 endometriosis, obviously you're not going to pick it up when you do a routine scan. So there are so many such things that we can actually look into before we label the patient as unexplained infertility. But does it mean that we should be actually doing all of this and then only we should come to any particular diagnosis? So it is still a matter of debate. So there is one school of thought which says that it should not be a diagnosis. You should get into the depth of it. You should find out what the problem is and probably then only treat. And there's another school of thought which says that these 3 investigations are reasonably good enough and you can continue with your treatment. Keeping aside all of this, what does the patient want? So are we justified by doing so many investigations? Ultimately, the patient wants faster success with less treatment burden. So they want a shorter time to pregnancy and they want less expenses in their treatment, right? So this is what the patient is aiming at. So the ISHRE 2023 guidelines very clearly state that a simple 3D ultrasound scan is more than enough to rule out uterine anomalies. You don't have to do an additional hysteroscopy. And diagnostic hysterolab is also not indicated routinely for unexplained infertility. So it's a very common practice among gynecologists that when all investigations we do are normal, you post them for a diagnostic hysterolab, hoping that you'll find something and you can treat it. It's quite a logical thing to do. But the guidelines state that you don't have to do a diagnostic hysterolab unless there are certain risk factors like a past history of PID or a previous ectopic pregnancy, or you have some suspicion about endometriosis, maybe the symptoms or something like that, or when the patient comes to us with an abnormal HSG. Only in these patients, actually a diagnostic hysterolab is what is indicated. What about the male partner? We have testicular imaging, we have anti-sperm antibody tests, we have genetic testing that is available, sperm DNA fragmentation, all of these tests available. But again, the ISHRE 2023 guidelines very clearly state that there is no role of doing all of these investigations as long as the patient has a normal semen analysis. But I want to highlight on one point here, make sure that your semen analysis is done in a standardized lab. So even today, I find patients coming to me with reports of 90% normal forms, 200 million with, and the lab report will give you normal values which are way, different from what the guidelines actually tell us. So many gynecologists here must be sending the patient to some place to get their semen analysis done. It's a good take home for you today that make sure that the semen analysis is done in a proper place so that you actually put the patient into the right pocket. You should not be missing a male factor by getting the semen analysis done in a substandard place where they're not following the guidelines properly. So now we are convinced that these three investigations, that is a simple scan, if it's good to add a 3D ultrasound scan, a tubal patency test, HSG hycosis is more than enough. You don't actually have to do an invasive laparoscopy, and a semen analysis. If these three investigations are normal, you can actually label the patient as unexplained infertility. So what are the treatment options that are available? So we have expectant management. We could do ovulation induction and timed intercourse. We could go for intrauterine insemination with or without drugs, or you can go for IVF or ICSI. So these are the options that are available. Expectant management, lot of importance is given because studies have shown that in patients, once they are diagnosed with unexplained infertility, 1 year later, 15% of the couples will conceive naturally. 2 years later, almost 30% conceive naturally. And 3 years later, almost 60 to 70% can actually conceive naturally. So a lot of emphasis is actually given to expectant management. So, but counseling is required. So once the patient has been trying for pregnancy for quite some time, they've been seeing a lot of doctors, they're very anxious. Especially, I mean, I don't know about the Western countries, but at least in India, they are extremely anxious and they want some treatment to be done right away. So counseling is extremely important. And if we are able to do that well, then yes, expectant management does have a role. What does the evidence say? So we have the NICE 2013 guidelines, we have the ASRM 2020 guidelines, and the recent ISHRE 2023 guidelines. So these are all huge guidelines. I can't go into each recommendation, but I'll try to give you a gist of what these guidelines tell you. So the NICE 2013 guidelines state that you can try for expectant management for a period of 2 years, and if the patient doesn't conceive, you can go ahead with IVF. So if the patient comes to you today, after trying for 2 years already, you shouldn't be waiting anymore. You can't say 2 years of expectant management then when the patient comes to you. Or if the patient has been trying for 1 year, you can tell her that maybe 1 more year of expectant management before they proceed for IVF. So they say that there is no role of ovulation induction and timed intercourse. There is no role of intrauterine insemination with or without drugs as per the NICE 2013 guidelines. Can anybody tell me how many of you can actually convince your patients to follow this? Anybody can raise your hands and tell me that, yes, I can convince my patient to follow this? Yeah, you are able to convince? Very good. Okay, there's one person here who can convince her patient after 2 years of expectant management, no medications, no more IUIs, straight away go for IVF. Okay. So there were 2 important trials that had come up at that point of time. So this is the FAST trial, which was to evaluate the role of FSH IUI in women between 21 to 39 years where they divided the patients of unexplained infertility into two arms. So the conventional arm, they went with 3 cycles of CCIUI, followed by 3 cycles of FSH-IUI, followed by 6 cycles of IVF. And in the accelerated arm, they went through 3 cycles of CCIUI, followed by 6 cycles of IVF. It's not a feasible trial which could have been done in India, but maybe because they are funded, they're able to do it, they're able to manage to get the patient go through all of this. The study shows that there is decreased time to pregnancy and decreased average cost of treatment with the accelerated arm. So now this is for patients between 21 to 39 years. Then came the fourth trial, which again looked at women who are slightly older. So between 38 to 42 years, women with more than 6 months of unexplained infertility were divided into 3 arms. So the first arm, they tried 2 cycles of CCIUI followed by IVF. The second arm, FSH-IUI followed by IVF. And third arm was immediate IVF. And what they said was that immediate IVF demonstrated superior pregnancy rate with fewer treatment cycles. So evidence was clearly pointing out that IVF is a good option in unexplained infertility. It reduces the time to pregnancy and the cumulative cost is lesser. So maybe that's how the studies came up and that's how the guideline also came up. Then we have the ASRM 2020 guidelines. Now the ASRM 2020 guideline states that there's no role of only ovulation induction and timed intercourse in a patient with unexplained infertility. So it's again a common practice where a patient comes to you, all investigations are normal, we end up prescribing oral ovulogents, ovulation induction drugs, and we tell them you can have timed intercourse and try for pregnancy. Because the patient wants to be prescribed some medicine, we also are happy to prescribe it. So the point here is a patient who's already ovulating naturally, you're not doing anything better by again giving her ovulation induction drugs. So ASRM states that IUI with oral ovulogents can be tried for 3 to 4 cycles. IUI with gonadotropins, they were not really recommending it because of the chance of multifolliculogenesis, multiple pregnancy, probably OHSS. And if they don't conceive after 3 to 4 cycles of IUI with oral ovulogents, we can go ahead with IVF or ICSI. Then came the ISHRE 2023 guidelines, which says, again, there's no role of ovulation induction in timed intercourse. IUI with ovarian stimulation should be tried for 3 to 6 cycles, which can include gonadotropins, but you should have strict monitoring. You should have a strict cycle cancellation criteria. So you should get the benefit of the treatment and also prevent the complications. And if they don't conceive, you can go ahead with IVF, or you can directly go ahead with IVF if you consider other factors which tell you that probably IVF is better for her. So this is the evidence and guidelines for you. I don't know, maybe you're a bit confused, but I'll just break this down for you. If you look at all the 3 guidelines, the NICE guidelines, the ASRM guidelines, and the ISHRE guidelines, all of them say clearly there is no role of only ovulation induction and timed intercourse in patients with unexplained infertility. So this again should be a second very important take-home message. When all the investigations are normal, don't put the patient again just on oral ovulogens and ask them to have timed intercourse and waste their precious time. The second thing is IUI with ovarian stimulation can be done. Use gonadotropins only if you are able to monitor the patient. So if you are not able to do follicular scans and monitor the patient, again using gonadotropins is going to be risky for you and the patient. So if you are able to do IUI with ovarian stimulation with gonadotropins with good monitoring and strict cycle cancellation criteria, that should be your second choice. So in general, we try to tell our patients that if you have been diagnosed with unexplained infertility, the first and best option for you should be IUI with ovarian stimulation. And if you don't conceive, we can go ahead with IVF. Or if you have any other additional factors which actually point towards IVF, probably that is what is recommended. So evidence is definitely not meant to define our practice. It is only to refine our practice. So this is the practical option that probably we can consider. So we look at the age of the female partner. If it is more than 38 years, unexplained infertility, we can directly tell her or counsel her for an IVF. But if it is less than 30 years, 38 years, probably we can do ovarian stimulation and IUI for 3 cycles, and if she doesn't conceive, we can go ahead for IVF. So now we know that the two practical options are, one is IUI and one is IVF. So can we do something different when we are doing an IUI in a patient with unexplained infertility? So there are 2-3 things that we can consider. So first thing is probably a superovulation. Maybe we can get a bit more number of follicles, which will increase the number of gametes that are available for fertilization. Can we do something different in a sperm preparation technique? And what about double IUI? So when we do a double IUI, logically it increases the number of sperms that are available, but does it actually help? So definitely superovulation, there is evidence which says that as the number of follicles increases, the chances of pregnancy might increase, but beyond the second follicle, the chances of pregnancy doesn't increase much, but the chances of multiple pregnancies significantly increases. So up to 2 follicles, as per all the guidelines, is still okay, but beyond the second or third follicle, I think it is always better to have a cancellation criteria. So whenever there are more than 3 follicles of 18 mm or more than 5 follicles of 12 mm, or there is a risk of OHSS in multiple pregnancy, it is always better to cancel the cycle. How do we cancel the cycle? This is a common question again asked. Many gynecologists call me. I have given only 2.5 mg letrozole. I have 4 to 5 follicles forming. What do I do? The best way to cancel the cycle is you just give her an agonist trigger so that the follicles rupture, they don't form cysts in the next cycle, and ask them to abstain from intercourse. So strict abstinence, give an agonist trigger, and don't worry about OHSS. The moment you see 4 or 5 follicles, everybody is worried. The patient might get into OHSS. What do I do? What do I do? So just give an agonist trigger, which is luprolide 1 mg or triptorelin 0.2 mg. Ask her to abstain from intercourse and ask her to come back on day 2 of the next cycle and adjust your dose so that this doesn't happen again. So what about sample preparation? Again, whenever we are doing an IUI, doing a density gradient is everybody's favorite. Doing a density gradient, they technically feel is going to give you good sperms. But this is a patient with normozoospermia. So in a patient who has all parameters normal, a simple swim up is more than sufficient. By doing a density gradient, you're subjecting the sperms to centrifugation, which might increase the ROS and increase the DNA fragmentation. So simple swim up is more than sufficient in patients with unexplained infertility. What about doing a double IUI? So the evidence says that a single well-timed IUI is as good, and by doing a double IUI, you're not probably going to increase the chances of pregnancy. Now, what about fine-tuning in IVF? Can we do anything different or anything better in an IVF program? So we discussed that probably ROS could be one of the reasons for unexplained infertility, which we are not looking into. Is there a role of giving oral antioxidants? Do we give antioxidants for 3 months before we start a treatment? Evidence doesn't really have a clear-cut recommendation that you have to give antioxidants for 3 months and start. You can as well start. What about microfluidics in IVF cycles? So can we do a microfluidics and select a sperm which has the least DNA damage and go ahead? So there are a few studies which says that by doing a microfluidics, you can get more number of top quality embryos, but it has no significant changes in the pregnancy or live birth rate. So you have to take it with a pinch of salt. What about IVF versus ICSI? Should we be doing ICSI for all to prevent a probable fertilization failure in patients with unexplained infertility? Again, the guidelines do not recommend ICSI for all in patients with unexplained infertility. It has been re-emphasized in the recent ISHRE guidelines as well that both IVF or ICSI can be done in a patient with unexplained infertility. So to conclude, I would say, first of all, make sure your diagnosis is correct. The 2 things where we lose on is, first thing is not doing a transvaginal ultrasound and not diagnosing a patient with poor ovarian reserve. When you're depending on scans which is done by somebody else, and especially a transabdominal scan where they just measure the ovary and they don't give you a report on the reserve, you're missing on that. So many patients just keep getting treated with oral ovulogens. After so many cycles, they come to us and we see she hardly has any ovarian reserve left. So doing a proper transvaginal scan, doing a 3D scan to rule out uterine anomalies, knowing her reserve is very, very important. Doing simple tubal patency tests are important. You don't have to do laparoscopy for all your patients. and doing a semen analysis in a standard lab who follow the WHO 2021 guidelines is very important. Only when all of these are done are you going to label that patient with unexplained infertility. And the best option would be to do an IUI with an ovarian stimulation with good monitoring and strict cycle cancellation criteria. And if they don't conceive, you can go ahead with IVF, or you can go ahead with IVF if she has other risk factors like age that is picking up and any other probable reason that you can be thinking of. So thank you so much. And in the process, you should tell her to keep trying naturally, because you never know, she can always conceive naturally. Even during treatment, we always encourage them that you keep having regular timed intercourse, and anytime you can conceive naturally. Thank you so much.